Hello, good afternoon, everyone. So I'll be speaking on radiation in locally advanced lung cancer after the neoadjuvant immunotherapy and surgery topic. So the flow of my talk will be the definition of locally advanced lung cancer, the selection of patient, time dose fractionation, and all the nitty-gritties of the radiation therapy volume and constraint. So what is locally advanced lung cancer? As we have discussed in the panel discussion, that so whenever the patient is of unresectable or we can say medically inoperable, we should term it as a locally advanced lung cancer, because if it is resectable, it would be called as an early stage lung cancer. So here, whatever is marked in the red, it's called the locally advanced lung cancer. So as far as the patient selection is concerned, so we need to take into account before we can plan for the radiation therapy in locally advanced lung cancer, the age of the patient, because it's not an absolute cutoff, but it depends on the performance status of the patient. PFT parameters, especially because so whether it is stage 1 or stage 3, the PFT parameters does play a role in the management of the radiation therapy. The comorbidities and interstitial lung disease, we should be very careful about interstitial lung disease before we can plan for radiation therapy. And the tumor factor, generally T1 to T4 we can treat, N3 crossing midline, but it depends upon the location and the laterality of the tumor. If it is a large volume and it is going to cause a significant amount of toxicity, so we should refer the patient to the medical oncologist for any role of systemic therapy upfront. And so we should be careful about the major airway involved if there is a collapse of the lung. The treatment factor, motion management is very essential. Linear accelerator, I would say, is a must. So because if you do cobalt, we cannot confirm the treatment volume. The planning system for the radiation oncology, the tissue heterogeneity correction should be done. The pulmonary rehabilitation, so with the involvement of the chest physician, is very important, because a lot of these patients will have grade 1 to grade 3 radiation-induced pneumonitis, and it is reversible or delayed if we can involve the pulmonary physician early into the treatment part. Now, so whether we should do the radiation alone or combined with chemotherapy, this answer was long been answered, that the radiation therapy plus chemotherapy does give a significant overall survival advantage. So we should combine radiation therapy and chemotherapy. So what should be the timing of the radiation therapy and the chemotherapy? It should be concurrently administered, as suggested by the operant meta-analysis. And I'm sure Dr. Bhavesh will speak a lot about that. So these are the radiation volume that you will have. So whenever you plan for the radiation therapy, you will have the gross tumor volume where there is a gross disease. The ITTV is for the motion management, is the clinical target volume is for the microscopic disease, and the planning target volume, because it's not a one-day treatment, it is going for approximately 40 to 45 days. So these are the radiation volume that we need to consider before we can plan for radiation therapy. There are ISTO-ACROP guidelines. However, the elective nodal irradiation is not routinely recommended in the radiation therapy in locally advanced non-small cell lung cancer. So it depends upon the PET positivity rate or the EBUS positivity or not. So we'll have to look to the guidelines. So this is the motion management I was talking about. If you see the left-hand side of the panel, the tumor will be seen as it is encompassed into the red structure or the red line. But if you involve the motion management, the volume of the lung or the volume of the tumor is significantly enlarged if it is located in the lower lobe of the tumor. So we need to have the motion management in place whenever we plan for the radiation therapy in lung cancer. So as far as the technique is concerned, there is no head-to-head comparison between 3D CRT and IMRT. But I would say that IMRT is significantly better as far as the conformity of the target volume is concerned, as well as the pneumonitis rate. So because the IMRT conform to the target very well as compared to 3D CRT, the chances of having the reactive pneumonitis is very less as compared to 3D CRT. And there is a meta-analysis of also the same. Now coming to the dose and fractionation, there was a lot of interest for the dose escalation before the RTOG 0617 was published, in which they have showed that the 74 gray volume or the 74 gray is more harmful to the patient as compared to 60 gray. However, there were certain caveats of the RTOG 0617. We are not going to discuss about that, but the uniform dose escalation is not the routinely recommended in stage 3 non-small cell lung cancer. So how can we alter our radiation treatment or radiation dose fractionation? So there has been a lot of interest in the 80s and 90s of the radiation treatment, that the altered fractionation schedule. So instead of giving it in a standard duration of 5 to 6 weeks, if we can give it in the 4 weeks of duration, there's an absolute benefit in the overall survival. But we should acknowledge that the esophagitis rate are significantly higher with accelerated fractionation schedule. Now, what are the outcomes of the chemoradiation therapy? We have seen from the 2009 till the data of the Pacific trial that we have improved upon the overall survival of the CTRT patient, right from 30% to the Pacific data of 5-year data of the approximately 42% in the Pacific trial. Now, so if you look at the patterns of failure, the most common two culprits are the local failure as well as the distant failure. So local failure is in the tune of 40%, and the distant failure is remaining to the 40 to 60%. So we need to act upon the local modality also, as well as the systemic therapy. So that's why the immunotherapy came into the picture as far as the Pacific trial is concerned. So immunotherapy, so when combined with the chemoradiation therapy, we have the Pacific trial. So it is the consolidation durvalumab, and it has improved the overall survival to approximately 42% at 5 years. There is an ongoing study of concurrent durvalumab, which is ongoing. Neoadjuvant durvalumab is also ongoing, and adjuvant pembrolizumab is also ongoing in the case of unresectable locally advanced lung cancer. So we will get more information about the concomitant administration as well as the neoadjuvant administration of the immunotherapy with the chemoradiation therapy. Now, I will also want to discuss the role of neoadjuvant chemoradiation therapy, because a lot of the European Institute do recommend neoadjuvant chemoradiation therapy before surgery. Thank you. So these are the list of the trial where you can see that the neoadjuvant chemoradiation therapy followed by surgery versus neoadjuvant chemotherapy followed by surgery. As Dr. Dolong has already said, that the downstaging and the pathological complete response are the important surrogate marker for improved overall survival. So if you see the neoadjuvant chemoradiation therapy trial, the pathological complete response rate were in the extent of 20 to 40%, and they have all improved the 5-year overall survival. But due to the concern of the radiation therapy in improving the surgical plane, they are not very popular as far as the neoadjuvant chemoradiation therapy followed by surgery. But it depends upon institute to institute. I've spoken to a lot of European guys, and they have said that we do practice neoadjuvant chemoradiation therapy, but it differs according to institute. Now, the downstaging, we all know that the importance, even if you have a pathological complete response, the overall survival is significantly improved as compared to a non-pathological complete response or an incomplete recession. We should also acknowledge about the complication of the chemoradiation therapy. Chemoradiation therapy will also come with their own side effect. The most common is the radiation pneumonitis. If you plan your radiation therapy portal well and to a lesser volume, the radiation pneumonitis rate of grade 3 will not be more than 10%. But if it is a large volume and the planning is not very particular, then the chances of radiation pneumonitis can be as high as 10 to 20%, and it can affect very significantly the quality of life of the patient. And the esophagitis rate, it also depends upon the length of the esophagus and the choice of the chemotherapy, for example, the etoposide. And obviously, so we are having a long-term overall survival with the help of the Pacific data. So we should aim to reduce the hard doses, because they have shown that the hard doses are having a negative impact on overall survival. So there are the risk stratification for radiation pneumonitis. We should keep the V20 as low as possible if we can, so to have the reduction in the incidence of grade 3 radiation pneumonitis, as well as the esophagitis rate. Now, I'll just speak about so 1 or 2 slides of the port in locally advanced lung cancer. So previously there was a controversial benefit of post-operative radiation therapy in stage 3, but with the help of the post-operative run of the lung art trial, it has been shown that the radiation therapy in adjuvant setting do not confer a significant benefit in terms of disease-free survival. And this has also been proven in one of the Chinese trials called the port C, that they have shown that there is no significant benefit in terms of disease-free survival. So, so I would recommend that not a blanket advice for the post-operative radiation therapy to all the patients. However, we can select the patient in terms of multiple node positive, or in the case of extranodal extension, the role of post-operative radiation therapy can be discussed. Now, so my take-home message will be for the radiation therapy that the radiation therapy is the standard treatment for locally advanced lung cancer who are unresectable. The patient's selection is very crucial. The concurrent chemotherapy obviously improves the overall survival. The radiation volume and planning should be of the utmost consideration, because so this is the area where you can reduce the chances of the toxicity as well as improve the overall survival. And obviously the immunotherapy with concomitant chemoradiation therapy has got a promising result, and we should await more in case of the neoadjuvant as well as the concurrent setting, the role of immunotherapy in locally advanced lung cancer. Thank you. Yeah.
So thank you, Dr. Anil, for such a wonderful presentation. And we move forward.